A very good morning and warm regards to respected Emeritus Chairperson Dr. M.L. Swankar Sir, Dr. S.S. Jaiswal Sir, all esteemed faculty members, colleagues and dear residents. I am Dr. Priyam Gupta, Assistant Professor, Department of Psychiatry, and I welcome you all to the CCR. This slide represents the heart of our department, our wonderful team of faculty and residents. The hard work and invaluable guidance of our dedicated faculty has led to the steady growth of our department. We established the MD in Psychiatry in 2010 with a single seat and grew to 2 seats in 2013. We have succeeded in increasing our training capacity and the number of seats to 4 in 2021 and further to 6 seats by 2025. Our department provides comprehensive mental health services across the spectrum. We offer general clinical care with daily OPD and 24/7 emergencies and inpatient care. We also run specialized clinic schedules on specific days throughout the week, including de-addiction, geriatric, psychosexual medicine, adolescent psychiatry. In addition, we offer advanced neuropsychological testing and consultation license services across other medical specialties. We have a total capacity of 30 beds for inpatients, in which 15 each are allocated for both male and female psychiatry wards. Also, I would like to draw your attention to the different neuromodulation therapies available in our department. We offer repetitive transcranial magnetic stimulation. It is an advanced, non-invasive brain stimulation therapy that is safe, well tolerated and used for different disorders like major depressive disorder, obsessive compulsive disorder and smoking cessation. Other therapies offered are transcranial direct current stimulation, modified electroconvulsive therapy, multi-behavior therapy and biofeedback therapy. As a department, we strongly believe in extending our services beyond the hospital walls to ensure community engagement and mental health awareness. Key outreach activities include OPD at Vatika PHC, community awareness programs, tobacco cessation services and awareness events. These initiatives reflect our commitment to preventive psychiatry and capacity building. Our department also leads the Student Mental Health and Wellbeing Committee, aimed at promoting mental wellness amongst the students. Through the Student Counseling Cell, regular workshops and stress management activities, we focus on early identification, reducing stigma and timely intervention. Students also have access to confidential counseling, crisis support and comprehensive psychiatric care whenever required. We honor Mental Health Awareness Week, that is 4th to 10th October every year, which is mostly centered around the powerful theme of community, highlighting how these social connections play extremely important role for our emotional well-being. This activity can always serve as a global reminder that we do not have to face our struggles in isolation and that true psychological resilience is nurtured when we support and heal together. Advancing psychiatric education, a core priority of our department, we have successfully spearheaded a number of conferences, CMEs, workshops and symposiums. Hosting the second Rajasthan Mid-Psychon 2025 was a notable achievement of our department. Simultaneously, we have been organizing CMEs for World Schizophrenia Day, World Bipolar Day. Our department takes immense pride for having such a distinguished faculty and dedicated residents who consistently secure academic excellence and recognition, both at national and international levels. Our residents secure prizes in paper presentation, competitive quizzes, and other specific events at regular intervals. For instance, our faculty has been a part as eminent members of, firstly, the Clinical Practice Guidelines Task Force of Indian Psychiatric Society, then School of Mental Health Task Force, and also the Executive Council of Rajasthan Psychiatry Society. Our faculty is frequently invited as chairpersons, moderators and panelists at national conferences and have also represented psychiatry at several prestigious platforms such as the Aura Women Empowerment event. Our faculty believes in acquiring new knowledge on regular basis and several of our faculty members have received awards for clinical excellence with additional qualifications for specialized training in child and adolescent psychiatry. reflecting our department's unwavering commitment to achieve perfection in clinical care, academics, research and leadership. Our department holds credit for multiple publications in reputed journals and books, coming up to over 100 publications in the last 5 years. Now I would like to invite Dr. Poornima to continue and start with our case.
A very good morning to our Honorable Chairperson, sir, respected faculty member and my fellow resident. I am Dr. Poornima Singh, a second year postgraduate resident from Department of Psychiatry. Before I begin, I would like to thank Dr. Priyam ma'am for her kind introduction. Building on this foundation, I will be sharing a case titled, A Young Female Looking Beyond the Obvious. This case is the perfect reminder that in psychiatry, the story behind the patient is just as important as the symptoms themselves, if not more. So, without further ado, let's just look at the patient initial presentation. A 20-year-old unmarried female resident of Kotputli, Rajasthan, currently preparing for NEET UG medical entrance examination. We gathered information from three main sources: the patient herself, her father, and her mother. Moving on to the OPD assessment, the illness has a duration of 10 months with an insidious onset and continuous course with episodic exacerbation. Patient presentation: after her NEET UG examination result, the patient experienced disturbed sleep with persistent low mood and crying spells since 10 months. Over the next 8 months, she gradually lost interest in studies and routine activities. In the last 4 months, she developed persistent suicidal ideation, which markedly worsened in the week prior to presentation. On the other hand, father had concern regarding social environment and behavior. He reported irritability and frequent arguments since 6 months, which created a lot of tension at home. He was also quite concerned about the friendship with the boy, feeling he was a bad influence who was distancing her from the family. The patient mother reported that over the preceding 6 months, the patient had gradually lost socially withdrawn with reduced interaction with family members and others. She also noticed frequent crying spells during the period. 4 months prior to presentation, the patient attempted suicide, following which psychiatric consultation was sought. The clinical journey. Every patient has two journeys. One is the illness itself and the other is the journey through the healthcare system. This slide represents both. Our patient journey began in September 2025 when the depressive symptoms first appeared. Like many patients, the first line of contact was the physician. Treatment was initiated, however, both the patient and the family reported no significant improvement and treatment records were unavailable. By November 2025, as symptoms persisted, the family started looking beyond conventional medicine and visited a faith healer while continuing treatment. This reflects a common pattern in our socio-cultural setting, where hope often leads family to explore multiple avenues before reaching specialist care. The turning point came in January 2026. What had started as untreated or inadequately controlled depression culminated in a suicide attempt by hanging. Psychiatric consultation was finally sought and the admission was advised. However, the patient family declined admission, highlighting how stigma, poor insight, and reluctance to accept psychiatric care can become a major barrier to recovery. During April 2026, treatment modification produced only a modest improvement of about 15 to 20%. But this improvement was short-lived. The illness continued to progress, remind us that partial response should never create a false sense of reassurance. Patient was compliant and was on regular follow-up. Finally, in May 2026, active suicide ideation brought the patient to the Department of Psychiatry at Mahatma Gandhi Medical College and Hospital. Family history. The patient belongs to an upper middle class family of Kotputli, Rajasthan. Her father is a CRPF officer, her mother is an Anganwadi worker. She has one younger sibling preparing for JEE examination. There is no reported family history of psychiatric illness or major chronic medical condition. Personal history. In psychiatry provides the psychosocial context necessary to understand the patient illness, personality, functioning and contributing factors. Moving on to her personal history, she was born at full term by normal delivery and her developmental milestones were achieved on time. She described her childhood as strict and restrictive, with close parental supervision and limited freedom to socialize. She is an average student currently preparing for NEET UG examination. She is unmarried and enjoys reading books and listening to music. She attained menarche at 13 years of age and had regular menstrual cycle. There was no history of substance use and she is vegetarian by diet. Pre-morbid personality. It is the patient's usual pattern of behavior, emotion and interpersonal relationship before the onset of illness. It was obtained from her parents, which reflect patient's low self-confidence, dependent on others for decision, responsible but prefer guidance, close dependent interpersonal relationship, fear rejection. When we put all these behavioral patterns together, our final clinical impression is suggestive of dependent personality traits. Examination. Next, we conducted a general physical examination to assess her baseline physical state. The patient was conscious, alert and oriented, and her vitals were stable and within normal clinical limit. Pallor, icterus, cyanosis, clubbing, lymphadenopathy and pedal edema were absent. There was no significant abnormality detected on systemic examination. On mental status examination, the mental status examination is the psychiatrist's version of physical examination for assessing the patient's current mental state. This approach is used to identify, diagnose and monitor signs and symptoms of mental illness. Each part of the mental status examination is designed to look at different area of mental function. Now patient mental status examination. Her general appearance was tidy and calm. Eye contact was initiated but she frequently looked away during the interview. Attitude of the patient was guarded. Rapport was established with difficulty. Psychomotor activity was decreased and speech tone volume rate was decreased with increased reaction time. Mood defined as the patient's persistent and sustained emotional state. It was subjectively reported as मन उदास रहता है, whereas affect, which is the patient's present emotional responsiveness as inferred from her facial expression, appeared to be depressed. Thought content, she stated, अब मुझे नहीं लगता कि मेरी जिंदगी कभी ठीक होगी. मैं चाहकर भी कभी कुछ बदल नहीं पा रही हूँ. मेरी कोई अहमियत नहीं है. मेरी वजह से सब परेशान है. ऐसी जिंदगी से अच्छा है कि मर जाऊँ. The inference from these statements were feeling of worthlessness, hopelessness along with suicidal ideation. Her higher mental function was grossly intact and insight, which is the ability to understand one's illness, was present in our patient. To bring everything together, here is the case summary outlining our clinical direction. We are looking at a 20-year-old female NEET UG aspirant who presented with severe depressive symptoms and suicidal ideation. She had already been receiving psychiatric treatment before presenting to us. However, her symptom persisted despite multiple treatment modification. Therefore, a psychiatric evaluation was undertaken to reassess her condition. In view of the severity of her illness and ongoing suicide risk, she was admitted to the female psychiatry ward for further evaluation and management. Based on these findings so far, what could be the possible differential of the patient? Yes, you are right. These consider differential diagnosis. Adjustment disorder was a prolonged repressive reaction and was considered. However, it was ruled out because the patient's symptoms were severe, persistent, associated with suicidal ideation and a suicide attempt. Dysthymia was ruled out as the duration of illness was only 10 months, whereas dysthymia required persistent symptoms for at least 2 years. Bipolar affective disorder was also considered, but there is no history of mania or hypomanic episode. Recurrent depressive disorder was also excluded because this was the patient's first depressive episode, with no history of any previous episode. Based on the severe presence of persistent low mood, marked anhedonia, disturbed sleep, and social withdrawal, significant functional impairment, persistent suicidal ideation and a suicide attempt, and an absence of psychotic symptoms, the patient fulfilled the diagnostic criteria of severe depressive episode without psychotic features.
So, can I ask a question?
Yes.
You make all these assessments just by talking to the patient, or is there an objective way to assess? Like you have a questionnaire, a score,
Yes, sir.
or you just talk to the patient and say, no, okay,
So
it
by
looks
the
like
history,
depression.
by the histories and the validated scales, we use HAMD scale, Hamilton Depressive Scale for this patient, which came out to be 26, which is severe.
So you have a objective way to...
Yes, sir. So we will discuss in the inpatient management about that. With this, I would like to invite Dr. Rohan Bhargava to discuss the inpatient management and subsequent course of our case.
Thank you, Dr. Poornima. Good morning, everyone. I'm Dr. Rohan Bhargava, resident of Department of Psychiatry, and I'll be taking this case forward. Now we move to a critical turning point, the inpatient admission. The patient was admitted in female psychiatry ward for a detailed diagnostic evaluation and further management. The primary reason for admission was ongoing suicidal ideations, along with persistent depressive symptoms and inadequate response to outpatient treatment. Admission was carried out under Section 86 of Mental Health Care Act 2017. This is the standard admission form that we use in our psychiatry ward under the Mental Health Care Act 2017. Before admitting any patient, we assess their decision-making capacity to determine whether they can understand, appreciate, reason, and communicate these treatment decisions. Following this, a detailed psychiatric evaluation was done. We administered the Hamilton Depression Rating Scale, or HAMD. Then, the Columbia Suicide Rating Scale for assessing her suicide risk. Finally, routine blood investigations were performed as part of the inpatient evaluation. This is the standard validated clinical scale we regularly perform in our department to measure the severity of depression in our patients. Her score came out to be 26, which confirms a state of severe depression. As the patient scored 4 on the HAMD suicide item, indicating severe suicidal ideation, we further assessed suicide risk using the Columbia Suicide Rating Scale. Based on the assessment, she was categorized as high suicide risk.
Can I ask a question
Yes,
here?
sir.
Like these scales, they are obviously developed in the West, possibly more applicable to the Western population.
Yes, sir.
Has somebody attempted or developed an Indian scale keeping in mind our socio milieu?
Yes, sir. Definitely, sir.
So,
There is Indian
do you
scales
administer the Indian scale also? You didn't show that, you just showed two
Yes.
imported scales.
Yes, sir. So they are more widely used and more acceptable. They are more valid. They are more reliable. That's why Hindi translation scales are also available.
But I think with regards to mental illness, the social milieu in the West versus our country is completely different. So I think there is a desperate need for a validated Indian scale. आप लोग सब होशियार psychiatrists, तो top department in the country, make a group of 5-6 good institutions and develop a Indian scale, no?
Yes, sir. Definitely.
We've done it for many spheres in oncology, not all, of course. We also have to use some Western scales, but I think it's needed, the need of the hour.
Yes, sir.
So, sir, actually Hamilton Depression Rating Scale, it is validated for Indian population as well. So we use it accordingly, and there is a Hindi translation which is available for Indian population.
Okay, agreed. But do you agree with my statement
Yes,
that the social milieu in India is different from the social milieu in the West, where
Yes, sir.
these scales are developed?
Sir,
Yes?
there are a lot of scales which have been validated for Indian population, and they have been constructed in case of Indian population only. So they are also available.
The point Hemant is raising is regarding the various questions which may not be, any scales. We also use in children with quite a number of scales which are validated in the Indian circumstances. But nowadays our academy has also started using Indian form scales, because the reason is some of the cultural differences have some subtle nuances in that questions which has to be taken into account.
Yes.
So you may be using a Western scale, and it may be validated also, but when we actually keep it in parallel to another scale which has been designed exclusively with Indian social milieu, you will find there will be a differences with there. You may land up over or under diagnosing that particular condition.
So that is the reason that we have different scales for Indian population as well.
Because the Indian situation is different. NEET exam is held only in India. 78 people have attempted suicide
Yes,
after this NEET exam. So
Yes, sir.
you need something different. In West you don't have the NEET exam.
Yeah, and you know, a teenagers in the West, as soon as you are 15, 16 years of age, you leave the house, you know, make it on your own kind of philosophy. Here, even if the child is 20, 30, 40, he or she still, you know, is very dependent on the parents. You know, so many differences,
Yes, sir.
particularly in the young people.
Based on this assessment, she was categorized as high suicide risk and the high suicide risk protocol was initiated, which is 24/7 strict monitoring of the patient by the nursing staff and the caregiver. All sharps and medications must be kept away from the patient. All medications must be administered by nursing staff or caregiver under strict observation.
So bedsheet और पंखे को कैसे हटाओगे?
So those are also the points. First, we have to remove the charging cables. We should remove all the ligatures. All possible instances have to be advised to the patient and the caregiver. If you are supervising the patient 24/7, this includes all those things like ligatures, ceiling fans, everything. But these three are the most core important suicide protocol.
Is the patient in a general ward with the other people around, or is she isolated in a single cubicle?
General ward.
That's also important.
Yes, sir.
Leaving alone a patient.
No, we'll never leave the patient alone. Absolutely, sir. We'll never leave the patient alone. The caregiver or the nursing staff has to be there. As shown here, all reports of the patient were within normal limits. Coming to the treatment review, before presenting to our department, the patient had undergone multiple medication adjustments under regular psychiatric follow-up since January. Despite adequate doses, treatment adherence and regular follow-ups, she showed only limited clinical improvement. This raised a strong suspicion of treatment-resistant depression, prompting us to further optimize her treatment after admission. So we strategically revised and optimized her medications. Escitalopram and aripiprazole were discontinued, fluoxetine was introduced, the dose of venlafaxine was increased to 150 mg, mirtazapine was added for augmentation and improved sleep and appetite. Lithium was optimized to 400 mg twice daily because of its mood stabilizing and anti-suicidal properties. Olanzapine was added as augmentation and clonazepam was continued for short-term management for anxiety and sleep disturbances. Electroconvulsive therapy and repetitive transcranial magnetic stimulation were considered as an adjunctive treatment to further improve clinical outcomes. Based on the findings so far, what could be the possible reasons for the poor outcome of the patient? At this stage, we went back to the basics. In psychiatry, poor response to treatment is usually explained by these possibilities: a wrong diagnosis, inadequate dose or duration of treatment, poor adherence or compliance, or an underlying organic illness. We reassessed each of these systematically. Our diagnosis was correct. The patient did not miss any prescribed doses. The patient was completely compliant with her treatment and had regular follow-ups.
I think the most important point you've not listed here is the removal of the basic reason producing depression. In your patient, the first sentence which you presented to us is NEET aspirant
declaration
and average student. So these are incompatible, these two
Yes,
statements.
definitely, sir.
So the moment you convince the patient that becoming a doctor is not the holy grail in life, everything will settle out, no? If
Yes,
you
sir.
counsel her for another career option, so that has to be number one point, no? The reason producing the depression has to be addressed.
Treatment plans. When patient was admitted, then cognitive behavior therapy and supportive therapy sessions were initiated, sir, during hospitalization.
But before you start any medication, don't you go in for a psychometric analysis on why the depression happened, what are the causes in therein?
That only we were discussing till now. That what are the reasons that we discussed in the further slide.
Because the treatment profile, the pharmacotherapy has been huge, but what was the counseling sessions regarding the causation of depression?
One more point, sir, I want to bring to your notice. And since it is a case of NEET UG, lot of competition in India, so you have not given a detailed account of scholastic performances right from beginning, in which subject the child was good and in which he was afraid of, the student-teacher relationship, also the friends and peer group who gave the idea of suicide, and as sir has already mentioned, the screen time and all that. So I think evaluation process history should have been a wide based, and then we could have gone to the further evaluation part and management.
Sir, in psychiatry, we have to assess the patient as a whole. And right now, when we were conversing with the patient, we have got many highlights and concepts that we will discuss right now. At this stage, we went back to our basics. In psychiatry, poor response to treatment is usually explained by these possibilities: a wrong diagnosis, inadequate dose or duration of treatment, poor adherence or compliance, or an underlying organic cause. We reassessed each of these systematically. Our diagnosis was correct. The patient did not miss any prescribed doses. The patient was completely compliant with her treatment and regular follow-ups. Organic factors like anemia, hypothyroidism, diabetes were ruled out. Still, there was lack of improvement. This was the clinical dilemma. We had assessed every factor, then what was maintaining her treatment resistance. This made us look beyond the usual explanations and re-examine the case from a broader perspective. During her inpatient stay, several important observations were made. The patient remained fearful and apprehensive, especially in her father's presence, avoided interacting with the doctors, nurses, and other patients, and spent most of her day in bed with marked psychomotor retardation and passively accepted the restrictions imposed by the father. The father's behavior was equally noteworthy. He refused consent for RTMS and modified ECT despite counseling, stating, "I don't trust these machines. They are only going to damage her brain." He remained suspicious of routine medical care, asking, "What are you putting in the drip? There are no adulterants in it, right?" and resisted blood investigations, saying, "Why do you need so much blood?" He refused hospital food, stating, "I only trust the food I brought with my own hands," and closely monitored his daughter's activities. He even shifted his daughter's bed in the corner of the ward and placed a bench in front of it, explaining, "I wanted to keep a check on my daughter when she wakes up or tries to go anywhere." At this point, we realized that medications alone could not explain the patient's lack of improvement. We decided to obtain a detailed collateral history from the family. The following slides highlight key observations from this history that provided a deeper understanding of the case and shaped our assessment and management approach. As the patient initially was guarded and reluctant to disclose her experiences, a separate interview was conducted over the next 2-3 days after gradually establishing rapport and gaining her trust. This provided a deeper understanding of the fears and experiences underlying her silence and distress. She stated, "मेरे पापा को मेरे किसी से भी बात करना पसंद नहीं है। अगर मैं किसी लड़के से भी बात कर लूँ तो उन्हें लगता है कि मेरा उससे कोई रिश्ता है और वही लड़का उन्हें नुकसान पहुँचाना चाहता है, जबकि ऐसा कुछ है भी नहीं। उन्हें लगता है कि दूसरे लोग मेरे को बेकार रहे हैं और मेरी वजह से परिवार में परेशानी हो जाएगी। पापा ने मेरी स्कूटी में GPS भी लगवा रखा है, जबकि मेरा भाई हर जगह मेरे साथ ही जाता है, फिर भी उन्हें भरोसा नहीं होता। वो मुझे फ़ोन भी इस्तेमाल नहीं करने देते, यहाँ तक कि पढ़ाई के लिए भी नहीं। मुझे समझ ही नहीं आता है कि वो ऐसा क्यों करते हैं। उन्होंने शादी के बाद मम्मी के साथ भी यही किया था, उन्हें उनके दोस्तों से और रिश्तेदारों से दूर कर दिया था। अब मेरे साथ भी वही हो रहा है। वो मेरे हर चीज़ पर नज़र रखते हैं, मैं कहाँ जा रही हूँ, किससे बात कर रही हूँ, सब चीज़ों पे शक करते हैं। मुझे तो ऐसा लगता है जैसे मैं कैद होकर रह गई हूँ। During the interview, father continued to show no concern about the suicide attempt, instead focused on who his daughter was talking to. Instead of seeing her medical symptoms, he kept restricting and monitoring her activities. मुझे पूरा यकीन है कि लोग हमारे खिलाफ प्लानिंग कर रहे हैं। अगर मैं सावधान ना रहूं तो मेरे परिवार को नुकसान हो सकता है। मुझे विश्वास है कि कुछ लोग मुंह ढककर मेरा पीछा करते हैं। वो हर जगह मेरी निगरानी करते हैं और मौका मिलते ही मुझे और मेरे परिवार को नुकसान पहुंचाना चाहते हैं। मुझे लगता है कि मेरी बेटी छुप छुप कर एक लड़के से बात करने जाती है, वही उसे हमारे परिवार के खिलाफ भड़काता है। इसलिए आजकल वो हमसे इतना गुस्से में रहती है और उस लड़के ने मेरे फ़ोन में कोई चिप लगा दी है जिससे वो मेरी हर एक्टिविटी पे नज़र रखता है। एक बार मेरी बेटी ने मुझे पसीना पोंछने के लिए एक रुमाल दिया था। उस रुमाल में कुछ मिलाया हुआ था। जैसे ही मैंने उससे अपना पसीना पोंछा, मेरा पूरा शरीर अकड़ गया और मैं हिल भी नहीं पाया। और उसी दौरान उस लड़के से मिलने गई थी। After interviewing the patient and her father, the mother was interviewed separately to obtain a collateral history. She stated, मेरी बेटी का कोई गलत इरादा नहीं है और ना ही उसका कोई किसी लड़के से कोई रिश्ता है। वो बहुत ही सीधी सादी लड़की है। वो सिर्फ पढ़ाई का बहुत ही ज़्यादा तनाव लेती है, इसलिए उदास रहती है। मेरे पति जो भी करते हैं उन्हें लगता है कि वो हमारी सुरक्षा के लिए ही कर रहे हैं। उन्होंने घर की दीवारें ऊंची करवाई और बेटी की स्कूटी में जीपीएस लगवाया इसी वजह से। हम तीनों, मैं, मेरी बेटी और मेरा बेटा, एक ही फ़ोन इस्तेमाल करते हैं जो ज़्यादातर मेरे पास ही रहता है। फिर भी मेरे पति को पता नहीं न जाने क्यों ऐसा लगता है कि वो उसका गलत इस्तेमाल कर लेगी। शादी के बाद से उन्होंने मुझे मेरे पड़ोसियों से भी मिलने से मना कर दिया था। मुझे अकेले बाजार या मंदिर जाने से भी इजाज़त नहीं थी, पर अब इसकी आदत सी हो गई है। Based on this assessment, what do you interpret as father's behavior? Was this strict behavior? Was it extreme overprotectiveness? Or was it something entirely else? The patient was not the only patient. In this case, the more we listened, the clearer it became that the illness extended beyond the patient herself. The father's behavior and statements raised significant clinical concerns, prompting us to conduct his detailed mental status examination. On assessment, he expressed fixed and unshakable belief that unknown people were following him, monitoring him, and trying to harm him and his family. He also believed his daughter and an unknown boy were conspiring against him. These beliefs were consistent with delusions of persecution, fixed false belief of being targeted or conspired against, despite evidence to the contrary, and also his insight was absent. Now we considered these differential diagnoses for the father. The substance-induced psychosis was ruled out due to absence of any substance use. Organic cause psychosis was excluded based on no history or systemic examination findings suggestive of organic pathology and normal clinical investigations including neuroimaging. Schizophrenia was considered but ruled out due to absence of hallucinations, negative symptoms, formal thought disorder, and preserved functioning. Therefore, the father's clinical picture was most consistent with persistent delusional disorder with chronic persecutory delusions and preserved functioning outside the delusional system. As part of comprehensive evaluation, the patient was referred to Department of Clinical Psychology for psychological assessment. I now hand over the presentation to Dr. Neil Joshi, who will discuss the assessment findings and their relevance to the patient's personality and family dynamics.
So how did you make the father agree to all this, like assessing by like the personality which you projected? It
Yes,
would have been really tough to have him admit that you have a mental problem and you need counseling.
Yes, sir. So initially, as I said, the patient's family has to be assessed as a whole. The patient is there and we have to see the web around the patient. All the aspects of the patient needs to be dealt with. Now, the father and the mother and the daughter. These were the three basic components. We had influenced the mother and the daughter that the father also needs psychiatric help. Based on the psychological assessment which Neil will just present to us, we had made the diagnosis that the father also had psychiatric illness. And with psychoeducation and with psychotherapies, he was also influenced that he needs treatment.
Most of the delusional disorders, they don't have insight and they do not come for treatment. But in this case, even patient's father was concerned about her daughter. So when we counseled that your daughter is suffering because of your behavior, so he agreed for treatment. Otherwise, most of the time they refuse the treatment.
Thank you, Dr. Rohan. Good morning, everyone present here. I am Neil Joshi, an MPhil resident from the Department of Clinical Psychology, and I will now take the case presentation forward. The daughter presented with depressive symptoms, suicidal ideation, and disturbed sleep, and father was referred for his suspiciousness and persecutory ideas. After obtaining a detailed case history and conducting the mental status examination, SAC sentence completion test and Rorschach-Inkblot test was administered to explore the patient's underlying personality dynamics and aid in case formulation. The first assessment administered was the SAC sentence completion test, or SSCT, which is a projective technique used to explore an individual's underlying conflicts, attitudes, emotions, needs, and interpersonal relationships. It helps identify unresolved psychological conflicts that may not be evident during a clinical interview. The SSCT for the daughter revealed significant father-related conflict and dependency, with her father being an important attachment figure and a source of emotional distress. This was followed by a strong need for validation and acceptance, along with family-related distress and guilt. She also demonstrated a marked fear of rejection and misunderstanding, restricted social autonomy, and low self-esteem. Most importantly, the findings indicated hopelessness, worthlessness, and suicidal ideations, particularly during interpersonal conflicts. The next assessment administered to both the daughter and her father was the Rorschach-Inkblot test, or RIBT. It is a projective personality test that helps us understand how a person thinks, feels, copes with stress, views themselves, and relates to other people. Before moving forward, I would like to give a disclaimer. The responses shown on the following slides are presented only to illustrate the process of Rorschach administration and to help understand how responses are elicited. In actual practice, no interpretation is made on an individual card. The final psychological formulation is based on the integrated analysis of responses across the entire protocol. Starting with the Rorschach examples of the daughter, this is card 4, commonly known as the father card, as it often reflects an individual's perceptions of authority figures and paternal relationships. I would like for you to please follow the black tracing, or the number 6. The daughter had mentioned, this is her verbatim, that बहुत खतरनाक इंसान है, उसका मुंह उस साइड पे है, ये पैर टच हो रहे हैं और ये उनकी ड्रेस है. Overall, the Rorschach protocol suggested an avoidant introversive coping style, indicating that although she appears emotionally controlled externally, she experiences considerable emotional distress internally. This is card 8. In response to this card, the daughter said, इसमें मुझे शिवजी दिख रहे हैं, उस साइड मुंह कर रखे हैं जैसे कि मुझसे नाराज है. Across the protocol, the patient demonstrated low self-esteem, emotional insecurity, and a strong dependence on significant attachment figures, particularly her father. Her emotional well-being appears to depend greatly on whether she feels accepted or rejected, making her especially vulnerable during interpersonal conflicts. Now moving on to the examples of the father. The first example is card 1, wherein he said, हाथ नजर आ रहे हैं, इस साइड से किसी ने पकड़ रखा है और खींच रहा है. ये आदमी जो खींच रहा है बहुत शक्तिशाली है. The father's response highlights themes of power and control, consistent with an avoidant introversive coping style. He tends to manage stress through withdrawal and control, with limited tolerance for emotionally demanding situations. The next example is card 5, wherein he said, ये पक्षी का आकार है और इसके गर्दन को चीर रखा है बीच में से. The father's response reflects themes of injury and threat, consistent with mistrust, suspiciousness, and hypervigilance. This may lead him to perceive threats and misinterpret others' intentions. The final example is card 9, wherein he said, ये आदमी जैसे दिख रहा है, जीभ बाहर निकाल रखी है उसने और ऐसे लग रहा है कि आदमी और जानवर का मिश्रण हो. The findings suggest that the father expresses attachment through overprotectiveness and control, particularly due to fear of loss. Overall, his profile reflects mistrust, suspiciousness, and controlling behavior, which interact with the patient's need for reassurance and contribute to ongoing family conflict. To conclude, the assessment findings indicate that the patient's personality is characterized by significant dependency needs, low self-worth, fear of rejection, and emotional inhibition. Along with her clinical history and symptom profile, these findings are consistent with a severe depressive episode without psychotic features. In contrast, the father's assessment reveals a personality marked by mistrust, emotional rigidity, hypervigilance, and a controlling interpersonal style. His overall symptom profile is suggestive of persistent delusional disorder. Taken together, these findings highlight that the patient's emotional difficulties are not only a result of her individual psychopathology, but are also maintained by maladaptive family dynamics. Therefore, treatment should focus on addressing both the patient's symptoms and the dysfunctional patterns within the family. Now I hand over to Dr. Poornima Singh to take the case forward.
Can you just go back to the SACS sheet? Now this, reminds me of what Mr. Karan Johar does in the rapid fire round. So is there when you administer this,
yes,
is there a Hindi equivalent available, and do you
there
give
is
enough time for the person to understand the question and answer?
Yes, sir. There is no time limit for this. There are 60 questions overall. I've just showed 34. There's a Hindi version of the test, and there are Indian adaptations as well.
These are well validated,
yes,
and adapted to Indian conditions.
Yes.
He is in the police, isn't it?
Yes, CRPF.
CRPF, yeah. So, have you gone to the history that he has had any kind of a very violent episode in the past which would have affected his behavior?
There is none that we have found through like case history. So the case history was such that there was more of him being rigid in his opinions, his beliefs, and the way he conducts his lifestyle. So that was majorly it.
No, because the origin is right from the childhood, or because of some kind of a strict parenting that he has got this influence, or is it during his profession he came across such incidents which have shaken his whole psychological makeup?
From as far as I remember, from his childhood, he has had a relatively strict parenting experience. He was advised to go into the army very young, early on. So he has been a very regimented person since early on. So.
Thank you, Neil. So to summarize the case till now, the daughter was admitted to the female psychiatry ward for further evaluation and management. Routine baseline investigation was unremarkable. On day 1, her HAM-D score was 26, indicating severe depression. Her previous medications were revised and an optimized treatment regimen was initiated. During the daughter ward stay, the resident and nursing staff observed several unusual behavior in her father. He also repeatedly refused recommended interventions including RTMS and modified ECT, despite detailed counseling and explanation. The observations prompted us to obtain a detailed collateral history separately from the daughter, her father, and her mother. Based on the history and ward observation, a detailed psychological assessment was carried out for both the daughter and her father. The daughter was found to have dependent personality traits, while the father has delusion of persecution. Clinical progression from individual to system. When this patient first came to us, we saw only depression. Then we saw the treatment resistance. Then we saw the conflicting histories. Finally, we saw the family as a whole and diagnosed the father with persistent delusional disorder. And that's when the entire case changed. The illness was never confined to one individual. Sometimes the most important diagnosis in psychiatry is not the one sitting in front of us, it's the one sitting beside them. The limit of pharmacotherapy, antidepressants were treating her biology, but she had to live in that same pathological environment. So we knew we needed a holistic approach for proper treatment of our patient. Multidimensional holistic management of the family, as treating the patient alone was not enough, we had to address the system around her. Daughter First, we ensured that patient immediate safety by admitting her to the female ward because of a severe depression and suicide ideation. Safety protocol was initiated. Second, pharmacological treatment was optimized and targeted her depressive symptoms and associated psychopathology. Along with pharmacotherapy, non-pharmacological intervention was also advised. Psychoeducation, in which we educate the patient and the family about the illness, treatment and importance of medical adherence. Supportive psychotherapy provide emotional support, reassurance and coping strategies to reduce distress. Behavioral activations encourage gradual engagement and meaningful and pleasurable daily activities to improve mood and functioning. In Suicide Safety Plan, we developed an individualized safety plan including identification of warning sign, coping strategies, emergency contact and restriction to access to lethal means. The father assessment was equally important. A detailed collateral history was obtained, followed by separate psychological assessment. Evaluation revealed persistent persecutory delusion. We applied a brief psychiatric rating scale. This is a standard validated scale routinely used in our department to evaluate the severity of psychotic symptoms. The patient scored 34, which fall in the moderate severity range. Following this, he was started on tablet risperidone 2 mg at bedtime for an initial 2 weeks and was advised regular follow-up. Psychoeducation was provided regarding the nature of his illness, the importance of treatment adherence and follow-up. Addressing the father's psychopathology was an essential step in creating supportive family environment for daughter's recovery. The final part of our management was to focus on her patient's mother, who was the primary source of support for her daughter. She was counseled separately regarding the family dynamics, with emphasis on the difference between protective care and overprotective behavior. The counseling also focused on helping us understand both her daughter's depressive illness and her husband's psychiatric condition. She was advised to monitor medication adherence, encourage regular follow-up visits, and promote supportive home environment to facilitate her daughter's long-term recovery. With this, I now invite Dr. Vasundhara to discuss the discharge, follow-up and long-term management plan.
Thank you, Dr. Poornima. Good morning, everyone. I'm Dr. Vasundhara Singh, resident of the Department of Psychiatry, and I will be taking this case forward. Following a 15-day inpatient stay, the daughter was discharged with improvement in depressive symptoms and an absence of active suicidal ideation. The father was managed on an OPD basis and continued on risperidone 2 mg HS. Follow-ups were planned for both the daughter and her father, emphasizing a family-based approach to treatment. Now let us look at progress made over the next month. As we had addressed both the patient and her family environment, we observed improvement in both. At the 2-week follow-up, the father showed around 20% to 30% improvement with reduced suspiciousness and decreased monitoring of his daughter. His BPRS score had come down to 28. Risperidone dosage was increased to 2 mg twice daily and trihexyphenidyl 2 mg OD was added. The daughter also showed nearly 50% improvement with fewer crying spells, restored sleep schedule and no active suicidal ideation, along with a HAM-D score of 14. Supportive therapy was continued and the mother was further counseled. By 4 weeks, the father had improved further with his BPRS score at 23. This reflected in how he had stopped tracking her or making such allegations. The daughter also showed nearly 70% improvement. Her mood remained euthymic. She had begun to participate in recreational activities and was also able to study for her NEET examination. Her HAM-D score had reduced to 9. So, clonazepam was at this point tapered and eventually stopped. This case shows us that treating a patient alone is not enough. Addressing the family system also plays an important role in recovery. In each follow-up, our goal was not just recovery, but also to prevent relapse. This was done by restoring the patient's confidence and functional independence, in promoting healthy communication and mutual trust within the family, and in continuing regular psychiatric follow-ups for both the daughter as well as her father. For the father, in order to improve adherence, we also planned a monthly long-acting injectable antipsychotic such as paliperidone palmitate to maintain continuous therapeutic levels and reduce relapse risks or missed oral doses. Additionally, we also taught the family how to identify and address early warning signs to prevent a relapse. Now, what is depression? Before discussing the diagnostic criteria, it is important to appreciate the burden of this disease. Globally, depression affects nearly 4% of the population. In India, 2.7% of adults, which is over 40 million people, are living with a depressive disorder. According to ICD-10, a depressive episode should persist for 2 weeks, and the 3 core symptoms are depressed mood, loss of interest or pleasure, and reduced energy. Additional symptoms include disturbed sleep or appetite, poor concentration, low self-esteem, feelings of guilt and worthlessness, hopelessness, bleak and pessimistic view of the future, as well as suicidal ideation. Based on the number and severity of these symptoms, a depressive episode can further be classified as mild, moderate, and severe. Now, what is persistent delusional disorder? Persistent delusional disorder is a psychotic illness in which one or more persistent, fixed, false beliefs, also known as delusions, occur lasting for at least 3 months, while personality, cognition, overall functioning remain relatively intact. Based on the father's history, behavior in the ward, and psychological assessment, we had diagnosed him with persistent delusional disorder. His delusions were characterized by an absolute, unshakable conviction that persisted long term and directly impacted his behavior, even while all other functional areas remained preserved. These beliefs directly impacted his behavior, particularly towards his daughter, and became a significant perpetuating factor in her own illness and recovery. I would now invite Dr. Rohan Bhargava to conclude this case.
Thank you, Dr. Vasundhara. Now, why we chose this case? What made this case unique? First, the patient's symptoms could not be completely explained by her own psychopathology alone. This prompted us to look beyond the individual. On assessing the family, we identified caregiver psychopathology as a major perpetuating factor. A detailed collateral history was then uncovered and undiagnosed persistent delusional disorder in father. This case therefore highlights the importance of assessing the family environment and caregiver mental health, reminding us that clinical picture does not fit. We should widen our lens from patient to the family. Now, the core lesson of our entire journey is the transformative power of collateral history. Before obtaining a detailed collateral history, the family conflict appeared non-specific and the father's behavior was interpreted as overprotective parenting. As a result, our management remained focused on the patient's symptom alone. However, after the collateral history was identified, the father's psychopathology was recognized and his delusional beliefs were driving his behavior. This shifted our approach from patient-centered symptomatic management to family-centered treatment by addressing the underlying perpetuating factor. The key lesson from this case is to look beyond the patient's symptoms. A careful collateral history changed our understanding of the illness and highlighted the importance of treating the family, not just the patient. Early recognition and family-centered approach are essential for better long-term outcomes. When society talks about a psychiatric patient, what is the image that comes to people's mind? They picture someone roaming around the streets, talking to themselves, completely lost and mad. We use labels like crazy or insane, but let's be absolutely clear. This is completely false, an outdated stereotype. Visiting a psychiatrist does not mean that you are mad or broken. Common everyday struggles like severe anxiety, persistent depression, and chronic sleep disturbances are all medical psychiatric conditions. They are as real as diabetes or high blood pressure. But because of the fear of being labeled, patients and their families stay silent, and by refusing to seek help, we allow the disease to worsen, prolonging the patient's suffering and dangerously widening the gap between the patient and the care they need. We must stop thinking this way. Mental health struggles are not a personal failure, and seeking help is a step of courage. We need to normalize early consultation, reaching out to a professional before things escalate rather than waiting it is too late. We extend our sincere gratitude to the patient and the family for their openness, trust, and immense learning opportunity. Mahatma Gandhi Hospital Management for providing us with the platform and continuous institutional support. Respected faculties and CCR Review Committee for invaluable guidance, encouragement. Department of Clinical Psychology for their teamwork, collaboration, and shared commitment to holistic care.